some practical actions to strengthen system alignment and delivery for BCYP across the region. We'll begin the session today with a keynote address from Professor Mitch Blair, who is an Emeritus Professor of Pediatrics and Child Public Health at Imperial College London. We'll be following that with another opening address from our colleague Alice Walker, a consultant in public health from the Greater London Authority. And then in the third section of the forum today, we'll have a panel discussion where I'll be introducing a range of leaders working on BCYP health here in the region to reflect on what this time and this moment of transformation means for this agenda. So stick with us today. It's an exciting agenda, and with that, it gives me great pleasure to introduce Professor Mitch Blair, and I'd like to invite him to give his talk as he reflects on his 40 years experience in clinical general and community pediatrics experience, international child health, child population health and preventive care. He has thought deeply about integrating services for BCYP and has led Northwest London's early years pilot. Mitch, over to you.
Thank you so much, Kevin. Just check that you can hear me okay?
We can hear you.
Great.
And we
wonderful.
can see your slides.
Kevin, I'm just worried about this fireside chat in a heat wave. I hope we'll have a cooler chat later on.
We have to adapt it for climate change.
Yeah.
Over to you, Mitch.
Okay, so and thank you for your introduction. I like the way you say my first 40 years, so I've got another 40 years to go. Anyway, I'm going to start by just saying a little bit about the work that I've been doing locally in the last few years of my career. And it starts with a quote from Frederick Douglass: "It's easier to build strong children than repair broken men." And I think many of you in this room will recognize that concept. And this speaks to the international work of the Nobel Prize winning Heckman, James Heckman, who's an economist, who showed, I think, without any doubt at all, that investment in early childhood brings returns in terms of human capital, both in the short term and in the longer term. So the more that we invest in prenatal programs, in programs targeted towards the earliest years, we have the best return. This slide comes from Harry Burns' annual report as Chief Medical Officer of Scotland some years ago. And I think it shows very beautifully the concept of how we grow the potential of our children through the life course. And the graph or the figure is divided into two sections, one showing the positive elements, if you like, to improve the trajectory of life, such as secure attachment, good nutrition, regular attendance at a good school, job opportunities, etc. And then at the top, some of the threats to that, which push down the potential for children: maternal smoking, alcohol, substance abuse, parental mental health difficulties, marginalization of minority groups, etc. I think that's quite a useful framework for us to keep in mind. And I've spent most of my career interested in early years. I started off as a community pediatrician in Nottingham, working in a health centre as a consultant pediatrician. So this is about 35 years ago. We actually worked in an integrated way at that time. The early years public health priorities in Northwest London are well known to you, I suspect. And I was quite interested to see how we could take this approach, these priority areas, and the neighborhood approach, and how we can bring those together and maximize the impact of people working together for children and babies in the Northwest London area. Why focus on early years? Well, I've already suggested to you the importance, the economic importance of doing that. But actually, from a health service perspective, and very interestingly, Northwest London, if you just take the infants alone, 59% of those infant urgent and emergency attendances are lowest acuity. They actually code as having no investigations or treatment needed, and that is the under ones. And that comes as a cost of just under £2 million. And I think it's a recognition that actually, although there's a lot of focus on the elderly in attending A&E, the under fives are actually the highest age attending group of any age group. What does the evidence actually tell us? That when you look at Sure Start, many, many years later, hospitalizations fell significantly in childhood and adolescence, with the strongest impact in the 30% most deprived areas. Systematic reviews show that early childhood interventions deliver lasting gains in cognition, language, emotional health, education, and employment. But it comes at a price. Complex local interventions take at least 3 or 4 years to mature, and probably 5 to 10 years to demonstrate a really good return on investment. So what is the background for the pilots that we undertook? And these pilots, I will explain, were funded by NHSE through Rachel Lundy and Duncan Ambrose at the ICB at the time. And they were funded to look at extending the existing model, which is the so-called GP Child Health Hubs, based on the Connecting Care for Children model, established over a decade ago, which was evaluated as being cost effective and now is part of official guidance nationally. And for those of you who are not aware, that is a system by which specialists, pediatricians, are working closely with GPs in their practices, seeing patients, but also operating a monthly multidisciplinary team meeting to discuss complex cases referred in by a wide variety of professionals and non-professionals in an area. The pilot was funded between April 23 and March 25 for 3 boroughs, Harrow, Brent and Ealing. And they were chosen because of the maturity of those child health hubs and also the strong local authority partnerships. The vision was to build a hyperlocal preventive care team around the most vulnerable families and connecting those families to the children's centres, family hubs, voluntary community and faith organisations to develop a fully integrated hyperlocal preventive care team. And this piece of work was evaluated by Imperial College colleagues, and one of the asks was to produce a toolkit to help other primary care networks and other organisations and public health professionals to develop similar ideas. So what does that look like? Locally, it is based around a PCN, maybe even 2 or 3 practices within the PCN, where within the most deprived or disadvantaged areas where there's an overlap of key indicators, and most of you will have got similar hot spotting maps in your areas showing the constellation of factors that come together and affect children's health and well-being. And it is in those areas that we want to pilot these sites. And the idea is that a family has both universal services delivered by the NHS on the right-hand side, within the primary care system, the Healthy Child Programme, health visiting, midwifery, etc. And then you have in the family hub system a similar universal family hub system for access, universal access by families in an area to children's centres, health promotion, financial advice, etc. And in the middle, you have this group of children and complex families who are often or having access to multi-professional input from lots of different areas, both social services, local authority, and health services. And that middle group is often the ones being discussed at the multidisciplinary team meetings. So that's the model. What does the international evidence show us about well childcare, the Healthy Child Programme, if you like, in this country, but well childcare from a WHO perspective? And an excellent synthesis of the literature done by John Eastwood and colleagues in Australia identifies 5 key areas, which you can read for yourselves. But what I found particularly interesting is the importance of both enrollment of preschoolers in quality education programs, but also enhancing intersectoral coordination, continuity of care, and supporting primary health providers. And this is what a hyperlocal preventive care team should be doing. We should be supporting each other with a focus on improving the health and outcomes of children, mindful, very mindful of the fact that the vast bulk of outcome is determined by socioeconomic and physical environmental factors, as well as health behaviors, with healthcare probably giving us about 20% of that outcome. What does that mean in reality for children in London? Well, we found, to our surprise, that 1/4 of the children that were living in the Brent area, under 5, were living in smoking households, in households with smokers. They were living next to polluted areas, as many children in London are, with relatively poor safety play spaces, often with a lot of conflict within the home environment, suboptimal in many cases, and a growing epidemic of child mental health issues. All of these things are well known to you in this audience. What is the value of that neighborhood multidisciplinary team is that each one of us is seeing a different part of the whole picture. And by bringing us together, we hope that we will understand better the family's predicament, the way they're living, where they're living, how are they living, and what we can do to support them. There are 5 common core components, I would suggest, to neighborhood integrated care. The first of which is proactive case finding, proactive identification of children, young people, parents, where there is high risk, and suitability for support. Secondly, shared clinical delivery, joint clinical care in community settings. Thirdly, holistic planning through multidisciplinary team case discussion. And not to forget the importance of ongoing learning from each other and the engagement and co-production with families to both make families aware of the issues affecting their children, but also having us become aware of the solutions, the potential solutions. In practice, when we look at the 3 boroughs that were part of this pilot, we asked the boroughs to focus on the areas they thought were most important. So in the 2 general practices, covering about 8,500 children, 870 children 0 to 4 in the target postcodes, which were 2 postcodes, 10 to 20% were missing their Healthy Child Programme reviews. There was an uptake of about 73% of MMR immunization, and there were high levels of speech and language delay and repeat ED attendances. So this is what we wanted to focus on in Harrow. In Brent, there was a real interest in respiratory under 5's health, and about 1 in 10 of those children under 5 have suspected asthma with no diagnosis made. These are the children that are bouncing in and out of hospital with preschool wheeze in inverted commas. And as I said, these children often are living in very poor circumstances and high risk for respiratory health. In Ealing, they wanted to focus very much on the fact that at the time of the pilot, about 32% of 2 to 2.5-year-olds were not meeting their developmental milestones, and particularly communication skills were the issue. In Northwest London, we are very lucky to have this whole system integrated care information system that helps us with dashboards. But very interestingly, when we looked at how many people access those dashboards, there were fewer than 25 individuals in the entire Northwest London sector who are actually regularly accessing these dashboards to find out more about population health. And that is something that could be discussed maybe later. So in Harrow, the first 1,000 days was the focus, with particular interest in perinatal and postnatal care. And I thank Lawrence Gibson, in particular, the Director of Public Health, who really got behind this project, and particularly because we had a strong and long history of high infant mortality in the area that we were focusing on. In Brent, under 5's respiratory health was the focus, and our aims were to reduce household smoking and confirm asthma diagnosis and optimize asthma care. And in Ealing, the idea was to extend the screening of social factors at the GP 6 to 8 week infant review, which is part of the Healthy Child program, both to improve parental confidence and to make sure that fewer children reach school with unidentified emotional and behavioral issues. The 6 core interventions were the hyperlocal preventive care team monthly meetings. We were very fortunate that within the pilot, Duncan, Ambrose, and myself had, along with other colleagues, had suggested that a proportion of the pilot should be allocated to innovation grants given to the local community for projects aligned to the key outcomes that the community was keen to address for the under 5s. The third element is community connector home visits, and what I mean by that are family link workers or community health and wellbeing workers who were able to go and make home visits and connect families to the existing statutory services. The fourth intervention was specialist community clinics, and we had 3, one for each area: postnatal, perinatal mental health group consultation run by general practitioners in Harrow, a preschool respiratory clinic run by a GP and a pediatrician, respiratory specialist, and in Ealing, the 6 to 8 week GP review clinic, which I mentioned before. The fifth was community outreach events, both health and well-being fairs, which were put on in the local community, as well as several different smaller outreach events, and then finally professional educational sessions. So these were the 6 core interventions, and we evaluated these and published only in May. And you will receive these slides, so you'll be able to look up in detail the evaluation, which were basically both a quantitative and qualitative approach to the evaluation of the pilots in 2 of the 3 sites in detail. To summarize, in a way, the community connectors is very much the glue in the system. They were trusted by the local people. They came from similar backgrounds to the families they served. And what they enabled primary care to do is, within a 7-minute consultation or 7 to 10-minute typical GP consultation, social prescribing is definitely an adjunct, which makes a very big difference. The difference here was that actually by making home visits, we were able to use the community connectors to bring families that wouldn't normally have access to, or normally frequent general practice, for them to be able to connect those families back into the statutory services. So they were able to signpost families, set goals, give practical help, bring cases to GP supervision meetings early and avert crises. And a wonderful case study, we had 21 case studies that you can read, and a very interesting case study in Ealing with a mother with schizophrenia who was housebound, had actually not gone out of the house with her 8-month-old baby. Her family link worker built trust over many months, and with several home visits, arranged for her to go for park walks, safety equipment, and alerted her GP when her mental health declined. And this had quite a profound effect on the baby in terms of development and gaining weight and babbling and getting speech and language skills, which were really becoming very delayed indeed. So this is a typical case study of probably trying to address the most vulnerable families in the community. The grants that I mentioned were dispersed at between £7,000 and £25,000 per grant. And I've just put up here the Harrow initiatives, which just give you a range of things that really made a difference. So teaching adult digital health skills for isolated families, the use of the Baby Buddy app integrated across Harrow maternity pathways, the baby bank workshops and professional drop-ins, cultured tailored health videos for the Somali and Arab communities produced by the voluntary sector, involvement of fathers with Home Start in the first 1,001 days, and then a fitness cafe for mothers aged 13 to 25, Ignite Youth. And that just gave us some idea of, or gave the community the opportunity to fund initiatives that they felt would make a difference. And these particular grants reached over 2,300 children across the 3 sites. I just show you the Harrow ones for illustration. The health and well-being fairs were set up and were attended by hundreds of local people. And this was post-pandemic. People were very hungry for getting together and learning together. There were workshops, there were stalls from everything from Citizen Advice Bureau to public health immunization services, and they were very well received. Cost was relatively modest, about £15 or £16 per attendee, and that included food, venue, and vouchers. 30 professional and voluntary organizations hosted stalls, and we had terrific feedback from all the 2 fairs that we put on, both in Brent and Harrow. And I think this was a fantastic opportunity for professionals also to learn about each other's services. What about the learning? We put on breakfast events called Munch and Learn, breakfast events at the children's centres for those people working in the neighbourhood. Obviously, that had the people's work schedules meant that was difficult for everybody to attend. But given a whole year's worth of dates, that made it much easier for people to adjust their diaries if possible. And we also trained 35 pharmacists to support parents and divert low acuity cases from emergency department using the Pharmacy First scheme. And that is still ongoing at the moment. This had a terrific effect. The speech and language therapists in particular, their referrals went down from 98 to 45 per month. The caseload went down to 500. The weights went down. The 93% of children were given targeted support, and 120 early years staff had been trained during the pilot period. So these neighborhood learning events really had a great impact. If we look at the clinics, just very briefly, the Brent Preschool Respiratory Clinic, the asthma action plans for 13 children. There were only 3 of the 13 had a plan. By the end of the clinic, they had 13, all 13, and all were followed up. And there was holistic allergy testing, mold, smoking cessation, and home visits, all put into progress by the Brent team. And that is ongoing and very successful so far, and hopefully to be scaled up. The perinatal mental health saw 38 parents to date in postnatal drop-in groups for women with mild to moderate mental health needs, almost invariably from ethnically minoritized groups at high risk, and plenty of link referrals to talking therapies, trauma and loss services, and peer support. And that was a very successful pilot. Professionals and parents have both said how much they appreciated these hyperlocal preventive care team pilots. Some of the barriers we can talk about in terms of GDPR and data access, funding, time to attend the MDTs, for example, or some simply not being invited and feeling excluded. So just to summarize 5 key findings: it takes time to co-design services and meaningfully engage communities. All 3 sites were operational at 2 years. Harrow, probably the most mature because we staged the pilots. The community connectors are absolutely key. They extend primary care's listening capability, and they allow us to really understand complex needs earlier and avert crises. Specialists and GPs really enjoy working together, and it raised the quality of clinical decision making so that this was a collaborative, relationship-based, joyful activity as opposed to a transactional activity. GPs are studied, very gradually discovering the value of family hubs and the voluntary sector as neighborhood resources, and we were able to, I think, put together some of that intelligence for GPs, and I think that is something that public health has a particularly good skill set for doing. And then finally, translating these national ambitions into practice needs very much better planning. You need a very strong and stable team for data, for governance, finance, and communications. And as you all know, this has been a complete churn over the last few years, and that does make it very difficult. And I mentioned that in this particular slide. 2 years is not enough. Complex interventions need many more years to mature, and 5 or 10 years to show real return on investment. So short-term economic benefits are very difficult to demonstrate in pilots like this. But the indicators, both process and structural indicators, are all showing that we're going in the right direction. We have produced a toolkit for those of you who are interested. It's a really good toolkit. I looked at it again yesterday and I realized how much work we put into it. Do please have a look. It does allow you to pick up on some of the things and really shortcut, I hope, some of the learning that we took many months to achieve. And then just to conclude, that we have, I think, proved that mature GP hubs, family hubs, and an engaged voluntary sector can wrap support around the most vulnerable families, that community connectors are the essential glue, that early quantitative and qualitative signals point in the right direction. And I cannot overstate the importance of relationships and trust and how that takes time. Sustained funding and stable teams are the price of full impact, and together we can all make a difference as an abundant community. Thank you.
Mitch, thank you so much for that excellent overview and really inspiring as well. I think one of the challenges that we know we have across many public health programs is that the evidence is there. The challenge often is the will to do it, and the capacity and capability and the funding to both implement and to sustain it. But what you've highlighted today are a range of tools for success, which are so critical for us as we think about this agenda. And I think this is going to set the discussion up quite nicely for the rest of the session. We only have a few minutes now for our chat, so I'm going to limit my questions to three, sort of rapid questions from you, just to get your reflections in addition to the lecture. I'm fascinated that as a pediatrician, you're so passionate about the neighborhood and place and public health and integration. What was it that shaped your own views on service integration as you went through your career, and why are you more passionate today than you may ever have been? I wonder if you could just take us through that, because in a sense we need to find that and bottle that with other practitioners.
I was very lucky. I thought that this was normal 35 years ago. I thought it was normal for us. That's how I was trained. I thought it was normal in Nottingham, inner city Nottingham, for specialists to be out in the community and to be working in neighborhoods.
Mm-hmm.
And my colleague and mentor at the time designed a patch-based system. So he called it Patch Pediatrics.
Mm-hmm.
So I never thought that there was anything different until I came to London. And I came to London and we had to start again. So I've always been interested ever since I was a senior registrar.
Okay, fantastic. One of the things you've mentioned and was clear in your presentation is the importance of community link workers. I wanted to reflect on that a little bit because during the pandemic, we again saw the importance of having representatives of the community co-producing, working closely with statutory services as an essential part of delivering culturally competent interventions, whether COVID vaccine, COVID testing, really dealing with myths and misinformation. Yet since the pandemic, we've seen a withdrawal of funding for that infrastructure. And in fact, many of our COVID community champions, we've seen loss of funding for those. What do you think are ways in which we can perhaps continue to bed that part of the health and care system, support that part of the system as an essential part of culturally competent programs and improving health? What more can we do to secure that workforce?
I think it's a tough question, Kevin, because there's quite a big push to do this nationally. There are excellent sites in Cornwall and in London and elsewhere where this is already happening, and it's happening through a variety of mechanisms. So in Brent, Amina, one of my GP colleagues, has put together has used the ARS funding, the ARRS funding, for funding this type of worker. But others have used different funding streams. My Director of Public Health, Lawrence Gibson, used public health funding directly. So I don't know. I don't think there's one formula. The one thing I would say is how important it is for these folk to be really part and parcel of the primary care team. I think the NHS bit of this is really, really important, both from a trust point of view, a community trust point of view, but also in terms of the governance and in terms of the overall supervision. And we found that those workers that were employed by practices, by the PCNs, were much more likely to have, were much less likely to have barriers put in their way in terms of communication, in terms of relationship. But how it's funded, I honestly couldn't tell. You would have a better idea, I suspect.
Well, I think many of us are looking towards the integrated neighborhood teams and the movement of the model to neighborhoods as an opportunity to do that shift from hospital to community, treatment to prevention, and within that, to do that in a much more holistic and integrated way with all the community assets. So that may be an opportunity for us neighborhoods. And it made me think about the programs that you developed in Northwest London, just in terms of the long-term sustainability, because your last slide says actually you need 2 to 5 years, 2 to 3 years for this to bed in, and then you need another 5 to 7 years, I think, or 5 to 10 years to show
Yeah.
real population health impact.
Yeah.
What do you think are some of the opportunities for sustainable programs in this environment that we're working in? Is it neighborhoods or is it public-private partnerships? What do you think we might be looking at?
I've been quite interested in some of the work done with Macmillan Nursing in cancer, with social value funding over longer periods of time. Nesta has had quite a strong input into that. So there are some very interesting models, community interest companies. There are some very interesting models. I think probably I would just briefly say that Bobby Jacobson
Yeah.
probably had it right when she
Mhm.
said there's so much at the time, there's so much churn, there's so much change.
Mhm.
Just keep your focus. Have 3 or 4 people. If you can keep your focus and
Mhm.
you're in an area long enough, and I'm very
Mhm.
lucky that in Harrow, I was there for almost 30 years, but
Mhm.
there were 3 or 4 of us who had been there for decades.
Mhm.
And it allows people, I think, to really get this and
Mhm.
actually understand it. And if they can sustain that relationship between the local authority, between the health services, and keep that going and retain the focus on the outcomes, then no matter what the churn, you will do it
Mhm.
despite the difficulties. It's up to the centre now to
Mhm.
facilitate this.
Yeah.
And that's going to take, I think, the, the framework, the neighbourhood
Mhm.
framework. It's going to take new funding streams. It's going to take contractual changes in job planning.
Mhm.
It's really a long next 2 to 3 years. I think we'll see a big shift
Yeah.
in levers to help align it.
Yeah. Well, on that note, I'm going to end with my final question to you, Mitch, which is if there was one policy recommendation you would give to the next Prime Minister, what would it be?
It would be the one that the previous prime minister said: education, education, education.
Education.
We've got to,
Fantastic.
we've got to have high quality preschool education, high quality health literate families. This is it's education. It's going to make the difference.
Mitch, thank you so much for joining us this morning. Please stay if are able
Hello,
to listen to the rest of the discussions
thank you.
today. You had a slide that really highlighted the keys to success, which I wrote down: proactive case finding, shared clinical delivery, holistic planning, learning together, and co-production with those who you're serving. And I think that really summarizes both the mindset as well as the approach that we need to disrupt the system to get different outcomes, but to keep the system working together in a different way, given the risk of fragmentation and the changes that we go through. So I think as we listen to the other presentations this morning, we'll come back to those 5 elements to look at them as consistent themes as we think about this agenda.
Thank you.
Thank you,
Thanks,
Mitch.
Kevin.
Great. Um, Moving on next, we'll hear from Alice Walker. Alice is a consultant in public health working with the GLA, and Alice has been working with colleagues to create the London Health Improvement Plan. This is a new health strategy for London, which was signed off by the Mayor and London's health and care leaders on the 1st of July. We're very excited about it because for the first time, it's a strategy in London that focuses on improving health, increasing healthy life expectancy, and reducing health inequalities. And in the plan, they are focusing on 3 key areas: improving children's health, improving mental health, and improving heart health. You'll be hearing more about the London Health Improvement Plan in the months to come as we finalise the document and we promote it. But this morning, we wanted to give you a peek look at the child health priorities in the plan and to hear your thoughts for our ambition for children and young people in London. Alice, over to you.
Thanks, Kevin. Hi, everyone. Really nice to be here and a real privilege to follow Mitch and that discussion with Kevin just then. I'm going to pick up on a lot of similar themes that were discussed in the presentation we just had. So I'm going to talk about the London Health Improvement Plan, and as Kevin mentioned, that was presented at the board last week, and BCYP is one of the 3 key priorities in the plan. So I'm going to outline how the draft plan was developed and then talk a bit more about the action areas within the BCYP priority. And as Kevin said, I work in the public health unit at the GLA, but supporting the development of the child health priority on behalf of the London system and the partners involved in the plan, who are listed at the bottom here. So NHS, the Mayor, London Councils, and OHID. So the mission for the plan is really about prevention and inequalities reduction. So in selecting the priority areas, the key question was how could a once for London approach really accelerate progress in the areas outlined? So really making sure we're capitalising on the power of regional partnership and also the power of this geographical footprint that we have. So with that in mind, the 3 priorities that were agreed by the London Health Improvement Board partners at the April Round Table, just going to the next slide, as Kevin said, were children and young people's health, mental health, and heart health. So I'm obviously going to focus on the CYP priority in the slides that follow. So just going to the next slide. I mean, I think everyone in this call will be really pleased to see CYP in there, and it really is acknowledging how critical it is to get things right for this age group in laying the foundations for lifelong health and well-being. And this is a plan for prevention and staying in good health. So for each priority area, so for BCYP, the plan sets out the opportunity, our ambition, and also the approach we plan to take with partners. And the aim there is to move from shared intent to practical action. So we're planning on developing the delivery plans over the next 9 months. And just briefly on each of the on each of the priorities. So for child health, we're envisioning 2 different types of actions. So the first one is exemplar actions. So these are things that show what becomes possible when London mobilises communities, institutions, employers, and cultural and sporting assets around shared outcomes. And then second is operational actions. So how can we address the less visible factors in order to unblock pathways? So things like data flow, aligning delivery, strengthening community engagement, and also creating more consistent approaches across delivery across the capital. So just for this slide, going back to the previous on this slide still. So there's the 3 delivery priorities, of which CYP is one, but the plan is also shaped by 4 cross-cutting improvement themes. So first is investing in upstream prevention. The second is driving innovation. The third is eliminating health inequalities, and the fourth is stimulating inclusive growth. So these aren't separate programs, but they're organising themes, and that will guide how the plan is delivered and how partners align their work. So these priorities and themes, they form the spine of the plan, and that will guide our approach and our actions. So going to the next slide, I'll just give a quick overview of the development process of these priorities, because obviously it was done quite quickly and it was a big task. So after the agreement of the 3 priority areas, for the child health priority, we looked at regional data and evidence, thinking really about both inequalities and preventability. We made a short list of potential action areas, and then we brought together a number of stakeholders from across the system to discuss that shortlist and to really understand where regional action would add value and where a partnership approach would be useful. Obviously, that consultation was not exhaustive, and there'll be much more consultation that will be done when we're developing the delivery plan over the next 9 months. So going on to the next slide. So this is the CYP priority as it appears in the plan. So on the left, you can see we've set out the challenge, and you can see here the real focus is on missed opportunities, preventable harm, and also addressing the determinants of health. So really prevention focus rather than treatment. And then the right outlines our approach. So these 3 areas that you can see quite small, but I'll go into depth on the next slide. These are the CYP actions in the plan, and I'll run through each of these on the next slide. So first is holistic and integrated services for early years, and that's really picking up on exactly what Mitch was talking about, shifting from reactive support to identifying needs and intervening early. London has lots of services in the early years space, but the challenges that families don't always experience in this joined up, especially families facing multiple pressures. And obviously, without joined up services and missing opportunities to identify needs early and provide support before problems develop. So this priority is really about organising ourselves around the needs of the family rather than the delivery of the services. And in integration, we're not just talking about health, we're talking about identifying wider needs, so housing and welfare, which we know will affect health outcomes. Obviously, integration is a kind of a magic bullet in a way, that's how we talk about it. But I think the opportunity for the plan is to really get specific about what good integration looks like for early years services. There's lots of amazing work going on across London. We've just heard about some of it. So it's a real opportunity to share learning and align approaches in a once for London way. And we really want to understand what the practical enablers that make holistic integration possible are. So things like shared intelligence and really trusted relationships. So how can we design our systems to facilitate more relational care, which is able to identify and support needs early? So the second action area we've called Thriving Through Adolescence, and we're still going back to the same slide. And here we're really focusing on thriving, not illness. This is about belonging, relationships, creativity, purpose, and opportunity. So we're incredibly fortunate in London. We've got amazing culture, sport, community assets. So the opportunity here is to harness these in a much more deliberate way as part of the prevention system. So really working closely with schools, community organisations, and the voluntary sector. So just a kind of flavour of what this might look like in practice. So exemplar actions could show what's possible when London's sporting or cultural institutions work with local systems for shared outcomes. And some operational actions might focus on better links between schools, youth services, mental health and employment support, for example. And the final action area for child health is called Learning for Safer Childhood. So this is about taking data, thankfully, which is very rare, thankfully, that's held on local footprints, and really using the data at scale to identify patterns and including upstream drivers of harm, which might not be seen as primary causes, for example. So using data from child death overview panels, for example, also integrating that with safeguarding data. So we're really trying to understand where a family is falling between services and how could earlier action change the trajectory and outcomes. So it's really about using London's geographical scale to learn better and act earlier. So exemplar actions might include, for example, thematic learning on recurring harms, and operational actions might focus on things like data sharing or stronger links between review findings and prevention planning. And I think also the other thing to mention about this is about creating joint accountability for prevention of harm across the systems. That's a really important point for that one as well. So going on to the final slide. This is about governance. So the oversight of delivery for the London Health Improvement Plan will be through the London Health Improvement Board. There'll be a small number of shared outcome measures and a strong commitment to learning and evaluation. So you can see in this slide at the bottom the timescales for the delivery plan development. The first one will be heart health, second one will be mental health, and we've got a bit longer for the delivery plan development for CYP. So that's due in March 2027. So over the next 8 to 9 months, we'll be convening partners, scoping opportunities for exemplar programmes, and looking at all the amazing examples of work already happening to draw out learning and identify pan-London operational priorities. So each priority area will have outcome measures and delivery metrics, and we'll be working really closely with academic partners to evaluate both implementation and impact. So that is the end. Just going on to the next slide. I think we've got a couple of moments for any questions now, but if you do want to get in touch to move into the delivery plan development stage, then that's my email there, and really happy to hear from everyone.
Alice, thank you so much. Really exciting to have that overview, and thank you for highlighting the 3 priority areas that we'll be working on. We do have time for some questions, so as they appear in the chat, we'll ask, but I'll start maybe reflecting on, as we were developing the plan, that tension that we had to carry for the few months, which is there's so much work going on locally and sub-regionally. What added value do we bring by doing this regional work and having a regional plan? And then how does that link with the work being done locally? Could you reflect on how these plans will sort of work with the system, and what are your hopes for their success?
It's really about I think that there's 2 different ways in which it can add to local action. First is about, sharing learning. There's so many pockets of amazing learning, and obviously people are so busy that we see a role here for amplifying and sharing that learning and thinking about what can we learn across this huge scale of this huge geographical footprint that we have and all the things that are going on. The second opportunity, I think, is around amplification. So I think the voice of this partnership is really a massive lever to amplify great practice that's already happening, and also to really shine a light on areas that maybe haven't been given so much attention to date. So I think those are the two key opportunities there.
Yeah, thank you. I'm really excited in the slide that you showed as well about the key cross-cutting themes that will be in every of the three priorities. So the focus on inequalities, the focus on innovation, the focus on spending, and how we bring that, and the focus on early intervention, how we bring that lens to the work. Why do you think that's so important in or work on children at this time when we're going through system transformation, having that focus on those lenses?
I think everyone in school will know prevention is always the hardest. The natural way of working is to work, to address the problems that we're facing rather to anticipate the problems that we will face in 5, 10 years' time. So I think really thinking about how we can systematically measure like the value of preventative investment would be a really big opportunity, and showing how investment into early years and preventative approaches at early years will translate into real impact, even if we can't measure that immediately. So I think shining a light and having that as an explicit area of focus is a real opportunity. And then the other ways of working, obviously, thinking about growth, thinking about inequalities, a real focus on that, and which is really important.
Yeah, I think it's exciting because the Health Improvement Plan has the Mayor of London, ICB chief executives, London council leaders, as well as academics and other partners around the table committed to this plan. So we have a major opportunity here as we go through system transformation to ensure we're keeping our eyes focused on a few things and driving delivery. Now, Duncan in the chat has a question for you, and he's interested in how the London Health Improvement Plan Priority for Children links to the work around SEND reforms at the moment. He thinks it's a great opportunity to align. What do you think?
Yeah, and that's definitely something we picked up from our stakeholder engagement. You'll notice that the action areas are quite broad, so they will accommodate. We wanted to make space for when we're developing the delivery plan to really think about what specific action areas can we address with this regional value add. So yes, definitely not, especially in the first two, so early years and supporting in schools. There's really opportunities, and really focusing on the prevention space, not overlapping with treatment work which is happening elsewhere.
Yeah, that's right. And I think as we design the health improvement plan, there are a number of North Stars that we had, right? The first is the shift from treatment to prevention. We really wanted this to focus on prevention and early intervention. Second, we wanted it to be additive, not duplicative of what was happening locally. And third, we wanted to use this as a way of either to unblock some of the barriers to making progress, or as you said in your presentation, to be exemplars, new ways of thinking and innovative ways to really drive new change. So in that respect, Lena has a question, which is a regional approach is really helpful for a population that is more mobile and where issues cut across boundaries. Would you agree?
Yeah, absolutely. And I guess this is like when we're thinking about regional value add, we're thinking about scale, we're thinking about mobility, we're thinking about sharing learning. There's so many opportunities to harness partnership work at regional level. And I think we've seen really great work in other regions in this vein. So yeah, definitely agree with that one.
Yeah. Danielle David had asked a question earlier on the maternity system, neonatal system, and the AMOS review. But Danielle, I promise I'll come back to your question because I think the panel discussion is going to have some fantastic speakers there that will be able to speak to this really well. And this issue of how do we learn from these reviews to fundamentally change how we provide services and to hold ourselves to account for better outcomes is one of the questions I'd like to ask the panel as well. Alice, I think we have time for one final question, and I'm going to take the question from Kath Evans, who expresses her concern about the 22,000 care experienced young people who often have the worst health outcomes in our population, and they will be future parents. So you have the intergenerational transfer of both trauma, risk, as well as the social and structural drivers of poor health. And Kat's keen that they're not invisible in this work. I don't know if you wanted to reflect on some of the discussions we've had and the clear steer that we've had about not leaving anyone behind.
And I think we were really mindful of this in the stakeholder conversations. That's why for the early years part, we really talked about children and their families. So thinking about not just, how do we support families where children are at risk of being taken into care or who are in contact with social services. So really providing family support, but also in the second priority about thriving, like how can we think about, supporting needs early as they emerge and thinking about people who are facing more difficult, more challenging life circumstances and supporting them through those rather than just to focus on health. So we've really tried to build it in, but it will definitely be picked up as part of the delivery plan process because we're really mindful of the fact that across the capital there's a huge number of care experience young people, so it's a really significant area of focus for us.
Wonderful. Thank you very much, Alice. I'm in the NHS building in Canary Wharf, and you may hear the fire alarm test just going off there. So I heard most of what you said, and I agree. That brings us to the end of the time that we have with you, Alice. Thank you so much for your work and leadership on this in the Health Improvement Plan. As you said, we've reached the first stage, which is developing the plan, articulating some of the key priorities. But the real work now begins with developing the delivery plan for the child health priority. And you'll be doing that over the next few months. That's correct? So we'll have a chance to come back to hear more about the detail that will underpin the approaches and our ambitions and metrics for the child health priority, as well as the mental health and the heart health priority as well. Thanks, Alice. And if you're able to stay, we have the panel discussion next. We look forward to hearing the final reflections from other colleagues. So, colleagues, we're in the final half an hour of today's session. I hope you've been enjoying the conversation today. We wanted to start off with the science and the evidence based on deep practice in place about what is necessary to help change things, the trajectories of the lives of kids, to change fundamentally how we integrate services, and the lessons that are being learned about how to do that well. We then heard from Alice, who told us about the London Health Improvement Plan, talking about strategy and what we need to do to ensure that we're fundamentally working to bed in and to lock in these changes, but at a strategic level and regional level to support work being done sub-regionally and locally. Now, in the last half an hour, we're going to go a little bit deeper with colleagues who are working at the coalface. We'll hear from our members, our panel members. First of all, Kirsten Waters, who is the Director of Public Health in the London Borough of Camden. I'd like to invite Kath Evans, who's the Director of Nursing at Barts Health NHS. Karen Bonner, who is the Chief Nurse in NHS London, and Dr. Amina Al-Yassin, who's a GP for NHS and Barnardo's in the London Borough of Brent and Clinical Director of Children's Services. We have just about 25 minutes with colleagues to do a little bit of reflection on what they've heard this morning and to say what it really means for us to do things differently to achieve different outcomes. So I'm going to ask colleagues, first of all, to come online. I think your cameras are now on. We'll spotlight the panel and we'll jump straight in. So first of all, I'm going to ask colleagues just to briefly introduce themselves and to outline one opportunity and one challenge for the BCYP system and services in the coming year. So Kirsten, we'll start with you. Welcome.
Thanks, Kevin. Hi, I'm Kirsten. I am Director of Public Health at Camden, and I'm the children's sponsor for the London Association of Directors of Public Health. So I know we're quite short of time, so I'll be brief. I think our key challenge this year is there's been an awful lot of system change and flux. I think we've got to acknowledge there's been a lot of organisational memory lost. So I think for me this year, it's really about stabilising our organisational and workforce ecosystem, because we can't get people to deliver what we need to for London's children when we have such flux. You know, that will come, but we have to acknowledge that as a challenge for all of us. I'm optimistic about the London Health Improvement Plan. I think that regional working's our superpower, and I think we work in a very complex system, and we are really able to knit well together across London. So I think that can really deliver. I'm also excited about neighbourhoods, not in the way that I think people think, because I think that children's services have been working in a neighbourhood way for time immemorial. And I think actually the adults have got a lot to learn about that. I think political and organisational spotlights on working with and in communities can strengthen our children's working. But I think that we have to really think about universalism and how well universal services have really supported our most vulnerable children. In Camden, we've made up a phrase which is targeted universalism, where we really want to centre our universal services really around our most vulnerable, hard to reach families. Because if we do that in a way that works for them, it will work for everybody. And I think sometimes we haven't gone far enough in that.
All right, fantastic. I love the phrase targeted universalism. I'm not sure if you've discovered it in Camden, but I love that you're using it as well. Kath Evans, welcome. Over to you. What's a challenge and an opportunity in the year ahead?
Oh, thanks ever so much, Kevin. And hello, my name is Kath, and I'm Director of Children's Nursing over at Barts Health in North East London. And as a children's nurse of over 30 years, not quite the 40 that Mitch was actually referring to, but I feel as though I've had an opportunity throughout my career to really remain connected with what matters most to babies, children, young people, and their families. And I think we've got a real opportunity to keep seeking that out and to keep working with the population that we're servicing. Their voices really matter. So over in Redbridge, we've got a group of young people, perhaps some more vulnerable young people whose voices are seldom heard, who've actually been working at place and at neighbourhood level, funded by some NIHR funding and working in partnership with our local university to really challenge the system to keep focused on what matters most to them. And what we've seen in North East London is a development of adolescent health care, GPs actually going to youth-based services with sexual health, with mental health, with social prescribing and youth work, and really meeting our young people where they want healthcare and preventative information delivered. So I think we've got a real opportunity there. With regard to challenges, I do think that we need to keep our focus and spotlight on the child health workforce. And I'm particularly going to give a shout out to our phenomenal health visiting colleagues, but also school nursing colleagues as well. And if I reflect back, we absolutely had an ambition to ensure that every school was supported by a school nurse. It's wonderful that we're seeing the expansion of the mental health in schools teams, but actually the contribution of school nursing can't be underestimated. And I'd really like us to focus on those elements of the workforce as we move forward. Thanks, Kevin.
Wonderful. Thank you, Kath. I couldn't agree with you more about the importance of the workforce, and I'm sure we're going to come back to this. I know Kirsten and I are also passionate about the child health workforce as well, because it is such a fundamental part of delivery of services, early identification, and tackling inequalities. So really want to come back to that a bit later. Next, Karen, welcome.
Good morning, everybody. Hello, my name is Karen Bonner. As Kevin's introduced me, I'm the Regional Chief Nurse for London. Very proud to be working at Region with Kevin. So a couple of reflections from me, if I may. So if I could just firstly thank Alice and Michael. I thought their presentations were phenomenal, and Michael's very inspiring, isn't he? And it's like those bits of London where you can really spread some of that learning. So firstly, I think in answer to your question, Kevin, is the biggest opportunity is delivering generally integrated neighbourhood team services and children's and young people's and families. I think the current focus on neighbourhood health, I think Kirsten's already outlined that actually they're already doing that, and we've got absolutely a lot to learn in other services as well. But really an opportunity to redesign services around the needs of children and families rather than organisational boundaries, of which often constrain us. And I think there's a real opportunity to bring together, as Kath already outlined, school nursing, health visiting, primary care, mental health, community services, education, social care, voluntary sector. So I'm very excited about that opportunity, and I want to give give a shout out to maternity. It's been in the spotlight the last few weeks, and it is not separate to this conversation. It's integral to this agenda, because that's where it all begins. And I think it's really important for me just to shout out our midwives and the opportunities we have with that integration around maternity. Biggest challenge for me, I actually don't believe anybody's hard to reach, to be honest with you. And that's one of the other reasons I think it's important that we do talk very much about being intentional on integration. But I think the biggest challenge for all of us is managing the increasing demand and complexity within the constrained resources that we have across London. We continue to see a rise in demand for mental health support, neurodevelopmental service support for children with complex needs, and wider wellbeing services. At the same time, the system faces financial pressures, workforce challenges, and organisational change. And there's a risk that we can become ever more focused on managing crisis waiting list, rather than investing in prevention, early intervention. If we're not careful, we could widen those inequities. So that's why the health mission and all the things that we're speaking about today are super important, that will benefit very early on. And those are my two reflections.
Yeah, thank you, Karen. And in our conversations at work, we often talk about how do you go against what sometimes feels like the pressure of focusing on the acute, the here and now, the A&E attendances, the elective recovery, when we know that we need to move upstream. We need to do some of those fundamentally shifts in order to reduce pressures. We're going to come back to that as well. Amina, great to see you. Over to you.
Thank you so much, Kevin. I'm Amina Al-Yassin. I'm a GP and I work in a really interesting space between the NHS and Brent Integrated Care Partnership, so the local authority, and with Barnardo's, the largest children's charity. And I think one exciting opportunity this year for children and young people is neighbourhood health. I think it's fantastic that children and young people are a named priority cohort, and that, you know, they are receiving the focus and the attention that they deserve. But I think that also leads me on to one of our challenges, which is that I think for a long time, we've been doing vertical integration really well. So where, you know, in many areas, this is very established now, where we've got secondary and primary care colleagues working together, pediatricians and GPs. And what I would love to see more of is more of that horizontal integration. You know, how do we bring in our communities? How do we bring in our green spaces? How do we bring in our schools and our VCSF organizations to all work together with young people? And the other challenge that I'm excited and energized about is we're developing a really, you know, a big wholesome system. How do we ensure that we are seeing the right people, that we don't wait for them to turn up at our doors? How can we be intentional about inequalities and find people before they get to that crisis point?
Thanks, Amina. I often say that when you build with equity at the forefront of your programs, then you don't need to correct for equity at the back end, right? So if we build, as you rightly say, for the people who are not at the table, who are hardest to reach, and as Kirsten said, you automatically develop a program which is fundamentally different, right? It might be universal, but it's shaped and feels different. So for the second question, I wanted to get your reflections, brief reflections on the presentations today. And if you could tell us a piece of work that you've been involved with that aims to integrate services for BCYP. So just wanted to hear from each of you very briefly on a project that you did, just to make it come alive. So what does integration feel like in your world? And this time we're going to start with Kath and then we'll finish with Kirsten. So Kath and then Karen.
Thanks, Kevin. And Karen gave me a really nice in, actually, because she mentioned the London Opportunities mission work. And I've been really excited and energised, particularly pinching Amina's word there, with regards to the collaboration that's really coming together, focusing on how do we ensure that all of our children across the capital reach a good level of development. So currently, about 75% of our children reach that level in their reception year. But we know that we've got some particular areas of focus that really need our attention. So those who are financially disadvantaged, those who are experiencing experiencing special educational needs and disability, those from Black and minority ethnic groups. So we've also got those in temporary housing, and I know that was an element in the chat box, as well as we were sort of, you know, hearing about earlier presentations. So I think building on Mitch's presentation, but also on Alice's health improvement work, is that real opportunity for health, public health, local authority colleagues to collaborate and to really shift the dial on making sure that more of our children are ready to learn and supported. And everyone's got contribution. So just last week, we had a workshop bringing together colleagues focusing on speech, language, and communication. And we had some expert speech and language therapists there. We had some brilliant early years practitioners. We had some great educationalists. And together we had a really rich conversation. And we particularly focused in one case study about a neonate and actually how we could better support our neonatal graduates to actually achieve better outcomes as well. And I think these really rich collaborations, discussions and relationship building is absolutely critical now as we move forward. And again, places and that neighbourhood work is going to really enable us to actually have those rich joined up conversations. But I think the London Opportunities mission, focusing on a good level of development and that collaboration, for me, is a really exciting one. And I think it sits alongside the health improvement plan, focusing for children and young people really, really well.
Excellent. Well, thank you, Kath. And I'm going to go to Karen, Amina, and then Kirsten for your brief reflections on integration opportunities that you're involved with that you'd like to shine as an example. So Karen, over to you.
Yeah, thank you. And can I just shout out to Kath? You can tell her passion. We're lucky to have her in London. So, and happy to support that piece of work. So just an additional piece of work just to flag. And I do want to shout out Rachel Lundy, who's already been mentioned, who is our programme lead in the region, who does phenomenal. So I'm not going to take any credit for any of the amazing work that this team are doing. But one of the things that we met and spoke about was, which is really significant for London, is how we support the implementation of babies, children, young people's multidisciplinary teams across London. So the work aligns with wider neighbourhood health agenda, aims to bring together professionals from health education, social care, public health, voluntary sector, provide the coordinated support for children and young people. Because we know traditionally families navigate multiple services, repeat their stories, experience fragmentation of care. So Rachel and team are looking at how we can better integrate and implement that. We recognise that it's not without its challenges, but that's the piece of work that we think if we can get that right will make a massive difference. So thanks to Rachel and team for prioritising that in the last few weeks. Yeah. Thanks, Kevin.
Wonderful and fantastic. Now, one of the challenges, of course, colleagues, is that we have, and London is full of great projects and pilots dotted all over the city. So one of the questions I'm sure I'll come back to you on is how do we move from the sort of pilotitis into scale? What does that look like? Amina, over to you. What's your example of integration?
Yeah, so in Brent, we used our local commissioning budget to introduce a child health check for children aged 6 to 10. We know they happen at the age of 40, and we thought they needed to happen much earlier. And there is this sort of almost lost bit of childhood between the reception and year 6 NCMP checks, where we found that our obesity rates in children were increasing fast and going unnoticed and unfound. So our child health checks, we worked very closely with our primary care colleagues and delivered these to over 5,500 children in the borough in 1 year. And they identified so many hidden inequalities. We prioritized children in core 20 postcodes, and we found that they had more than double the rate of being incompletely vaccinated, or living with a household smoker, or having other concerns. And so as a result of that, we really sort of galvanized our system to shift things around and do things differently, including working with children's link workers and developing a mental health single point of access in our borough. And the thing that the one bit of data that really stayed with me is when we look at our asthma diagnosis in Brent, previously, a child in Brent was much less likely than a child in their neighbouring Northwest London boroughs to be diagnosed with asthma. And as a result of this really intentional, focused work, they are now actually 1.8 odds ratio, so more likely to be diagnosed with asthma. And that just tells me that, you know, inequalities are complex, but you can do something about them.
Yeah, absolutely. And it requires focus, leadership, funding, accountability to make that difference with inequalities, Amina. So thank you so much for giving that example. Kirsten, over to you. Your example of integration.
Thanks. I mean, I think the part of the presentation which really resonated with Mitch's comment at the end is about education, education, education. And most children's life and childhood experiences are not shaped by health services. So I think the challenge for us is how we are working with schools, early years, play, the things that make a rich and happy childhood. The example I'm going to give about integration is really about data linkage, because I think we need really strong foundations. So in Camden, the team, Carla's on the call today, we worked with DWP and the NHS to link data to offer a £500 unconditional pregnancy grant. And the aim of that was to reduce low birth weight, but also to improve pregnancy outcomes. Now, that was an unconditional grant, but required no application. And on receiving the £500, women had contact with a family navigator who gave them a warm welcome to children's services and benefits advice. That work's been evaluated by Nesta, and we'll be happy to share some of that. That required an awful lot of data linkage. And if we're talking about integration and we're talking about workforce integration and system integration, we need those strong foundations and that solid house structure in order to do the work, and also to help professionals do the work as well.
Mm-hmm. Thank you, Kirsten. A great example there. And I love the diversity of examples that you've all used and shared to show that integration can be in different domains, in different partnerships for different outcomes. I'm now going to start with you, Karen, as I'm trying to be equitable in how I start the session and go around the group. I go to Amina and then Kirsten and finish with Kath on this. The challenge is we know what to do, but things are not either funded or sustained, or we somehow, with transformation, we lose momentum. That is a big risk for us. Karen, what do you think are going to be keys to success of surviving this transformation that we're going through now and landing in a better place for kids and young people? And I'm going to ask different questions to each of you, building upon what's coming in from the chat. But Karen, I'm starting with you first on this one.
Yeah, thanks, Kevin. I think we can't underestimate the organisational restructures and service integration work. All of this can slow down some of the work that we're doing, actually. And I think what I would say is important, if we keep the needs of our children and young people at the centre of our decision making, our restructuring, and is an opportunity to strengthen partnerships. So you've mentioned about funding, money, and often I hear the story, we haven't got any money. There is money around, we do know this. It's how we utilise it, how we break down those organisational barriers to be much more innovative in sharing across the system in a way that it benefits everybody. So I think it's really important for us to keep our families and children at the centre of decision making, restructuring, opportunity to provide and strengthen partnerships, not weaken them, because actually where we're all consolidating, and it can strengthen partnership because there's much more stronger if we get together, like Cass already outlined. If we work closely with other partners, we can actually strengthen what we need to do across London. And it's the challenge is to ensure that we don't lose momentum on improving outcomes while we're going through the change around us. And I think they're the things we've always got to keep an eye on. And it is a challenge, but I think there's an opportunity at the same time. I hope that answers your question, Kevin.
It absolutely does. And I just want to reinforce this. The leadership challenge as we go through change is having focus, having that strategy, deep partnerships and collaboration, and holding ourselves to account to achieve specific outcomes, right?
Absolutely.
So keep focusing on a few things, I hear you say, and keep doggedly through it. And that is exactly what we need right now, and which is why I think the London Health Improvement Plan is coming at the right time, because it is again helping us to focus on a few things as we go through change. Amina, you spoke about horizontal integration. I love that phrase, because you're right. Actually, there's a danger that we create neighborhoods, but it's focused on vertical integration, not horizontal. And as I said in the lecture with earlier, often we have community workers, but they're not funded. We have collaborations, but they're not sustained, social prescribing, etc. How could we use this new shift to create neighborhood teams to lock in a horizontal integration sustainably? What do you think we can do?
Yeah, that is such a fantastic question, Kevin. What we've noticed is actually these roles do tend to exist in all sorts of shapes and forms in different organizations. And about mapping exercise we did in Brent found that we had social prescribers and community link workers and earlier, different practitioners. And it's actually about thinking about how we can bring them together, maybe have joint commissioning models, maybe think about the resource that's available across our system rather than in every organization. And I think that in doing so, it will not only bring more sustainable funding, but bring more sort of shared accountability and investment and supervision into these roles, which is what they really require, because the cases that they are handling can often be increasingly complex.
I agree. And maybe I think, one of the things I'd love to work on is that we view horizontal integration with the same rigor and value that we do the vertical integration. In other words, we fund it properly, we develop the sort of relationships, we look at metrics to understand how well those horizontal relationships are working, and we hold ourselves account to good horizontal working, because otherwise it feels as if we have a value judgment that we focus on any avoidance rather than the community work. But I'd love to hear what people think in the chat. Do we value this horizontal working within neighborhoods effectively, and are we resourcing it effectively to have the outcomes we need? Kirsten, I'm going to come to you next because I really wanted to come back on targeted universalism, and I wanted to hear from you. How would you use it to solve some of the wicked problems that we're grappling with, whether it's the rising mental health issues among our young people, or declining vaccination rates in the city, or maybe another challenge that you're using it for in Camden? Can you bring it to light in terms of what you actually do in that approach?
No, thanks, Kevin. That's a great question. This is across all of our services. So this is not just applicable, I think, to health services. I come from, employed by local authority. This is around children's centres. It's around education. It's around really making sure that our services are geared to those with most capacity to benefit. And I think that's, something that we take really seriously. The work that we've been doing with the Institute of Health Equity in Camden has been doing some structured equity audits, looking at who is coming to our services, our universal services. That's really important. So I think we have to approach this in quite a structured way. Do we know which families are accessing weaning services? Who's coming to stay and play? These are the questions that services on the ground should be asking ourselves. And for us, it's really about empowering our frontline practitioners. Some of the feedback we've had locally when we've been doing these audits, and an audit's quite a formal sort of way, but we see this as quality improvement, continued quality improvement for services, and empowering multidisciplinary teams to be able to take this work on themselves. Their feedback to us was saying, well, we used to run stay and play or weaning, and we just wanted people to come. We wanted the room to be full, and we wanted to see lots of families. Now we ask ourselves, which families are not coming, which families are missing? And that's exactly the kind of questions we want, because I think that this should be designed from on the ground, and the principle of subsidiarity is really important here, because your family centre workers, your health visitors, your school nurses will really know the communities best. So they should be able to do this work. We should devolve this work down. And I think some of the work that's been happening regionally and nationally around the 0 to 19 quality improvement work, which has been led by NHS England and DH, is really important around empowering our frontline staff, particularly health visitors and school nurses and our early years workers, to be able to do some of this work themselves. So for me, targeted universalism is, I guess, a bit of a theory, but it has very practical implications and really should be seen as this cycle of quality improvement.
Wonderful. Thank you, Kirsten. Kath, we're going to finish with you. And the last question is there one system change for BCYP in London that you would like to see? And what would it be, that one system change?
Oh, I think we need to get talking to each other more, Kevin. If that was my one ask in terms of, you know, relationships and keep actually reaching out to each other. So just last week over in Newham, we brought together our mental health services, our health visiting services, local authority, public health teams, maternity, children's inpatient services, ED services. We had children's ED doctors there. And together we had a really rich conversation about our place-based work, what's happening, where are our big opportunities, and how do we keep collaborating. So let's keep having those conversations and joining the dots, Kevin. Our babies, children, young people and families absolutely need us to keep talking and keep collaborating as well.
What a wonderful way to end. Kath, Kirsten, Karen, Amina, thank you so much for participating in the panel discussion. I hope you enjoyed it. And thank you for bringing this subject to light with your examples, but also your passion and your focus on what we need to do next. And a huge thank you to our other speakers today, Professor Mitch Blair and Alice Walker. And thank you all for attending this Public Health Forum event. We've had nearly 200 attendees attending on this event, and the event itself will be recorded and will be made available. Our next forum will be in the autumn, and invitations are going to be sent out shortly. It's going to be an opportunity for London's public health system and public health colleagues from across the country to come together as a community to discuss hot topics, tackle some shared challenges in this ever-changing landscape. Finally, a huge thanks to our OHID London team who worked behind the scenes to ensure that the forum was well organised, and our partners working with other regional organisations. Huge thanks to all the work you've done to make this a success. Finally, colleagues, in closing, a reminder that Faculty of Public Health members are meeting straight after this forum. If you'd like to attend, and if you're not already in receipt of the calendar invite, please email Lorna Jane. Her email is in the Teams chat, and she will forward you the calendar invite for the Faculty of Public Health meeting for members if you haven't yet received it. Thanks again for attending. Take good care, and thank you for all you do. Bye-bye.